Hi, Nalini. I was not.
Hi, I was saying
actually,
hi, you were muted.
I was muted, so I could say hi, everybody. So I'm
You haven't gone for Ashray?
tomorrow, day after.
Left.
You are going?
नहीं नहीं
नहीं जा रहे?
I'm going to Masai Mara. I'm going to Nairobi.
अरे वाह.
So, more interesting things to do.
I think बहुत काम कर लिया. Do some interesting things also.
Absolutely. Where is it this time? Copenhagen?
Amsterdam.
Amsterdam.
I'm also going after 3-4 years.
It's almost becoming like Foxy the Ashray, you know. There's so many people, and you're just running from room to room. By the time you get to the other room, what you wanted to hear has already passed. So मेरे को काफी time हो गया. Unless it's in a place I want to visit, I don't go.
मुझे भी काफी टाइम हो गया था. Just for that reason, I thought I need to update myself. चलो. I think Lovely start करते हैं.
ठीक है, we'll start, ma'am.
हाँ जी, just a minute.
Good evening, everyone, and welcome to our webinar on fertility preservation, which is a collaborative effort by the Fertility Preservation SIG and the IFS Greater Chandigarh chapter. We are incredibly fortunate to have such knowledgeable and experienced speakers with us today, and I'm sure we will gain valuable insights from their presentation. Now, I would request Dr. Rita Mahi, our convener for Fertility Preservation SIG, to please commence with the welcome address.
Thank you, Jasneet. And first of all, I think respected Dr. Nalli ma'am, thank you so much to agree to mentor us and to guide us to make this program happen. So this is our first effort to do this SIG on a very important topic, which is today's need of the hour, this fertility preservation. And thank you for agreeing. And so may I please request you to please say a few words of wisdom to us so that we can start our program.
So the wisdom before the presentation, is it? No, I'm incredibly honored that you have invited me and feel very proud that you're taking this field forward. It's such a niche area, and when we started, we had very few takers. And today, of course, every meeting has a session on fertility preservation. So I think that in itself makes me feel very happy that awareness is increasing. And as we see on the social front, I think every day I receive 3 or 4 phone calls or patients coming in for elective egg freezing. So it's really completely exploded this area. But I think the more challenging one is the one that we do with cancer patients, because it's a very high risk group of patients it's their last chance at reproduction, having some sort of backup. So yes, I think that is the area where we should really focus. Social freezing is mainly about the procedure and maybe counseling people on what they should expect of the procedure, because they go into it thinking that okay, now it's my backup plan, it's my insurance, and I'm going to get pregnant, but it doesn't necessarily mean that. So counseling in social freezing is extremely important area.
Yes, ma'am. In cancer also, I think this counseling is very important, because usually they come to us like they have been sent. They don't even understand what is the procedure. They say कि बस cancer वाले doctor ने भेजा है कि कुछ होना है बस आप कर दो. So and I think we have learned so many things, because we have grown during since my residency days. I have been listening to your lectures of oocyte freezing and OTC.
Okay.
I definitely, ma'am, for years I think we are seeing your inspirational talks on fertility preservation. You are the one to start actually in India. So thank you, ma'am, for agreeing. So can we start the program, ma'am, now?
Definitely.
Dr. Jasneet, please. Yes.
Thank you, Dr. Rita. Now I invite our chairpersons for today's first session, Dr. Umesh Jindal, Dr. Lavleen Sodi, Dr. Manu Goyal, and Dr. Anshu. and to kindly chair our first session, which is on dilemmas in fertility preservation by Dr. Nalini Mahajan. So Dr. Umesh Jindal actually needs no introduction. We all know her. She's the pioneer in IVF and infertility management in Northern India. And she was actually the first to start IVF, ICSI, vitrification, and PGT in Chandigarh. And she's been a mentor to many of us. Dr. Loveleen Sodhi, she is the Director and Chief Consultant at Sodhi Healthcare Multispeciality and IVF Center. And ma'am is presently the Secretary of the Greater Chandigarh chapter of IFS. Dr. Manu Goyal, I don't think she's here. She's the additional professor at AIMS Jodhpur. And Dr. Yadav, I think she'll be joining us shortly. She is the Director Consultant Gynecologist at Jigvisha Hospital and IVF Center in Rewari. Now I request Umesh Jindal ma'am to kindly introduce Dr. Nalini ma'am.
I would say again, Nalin needs no introduction. And you have already said that she was the one who started fertility preservation, the concept of fertility preservation in India, and the society also. And she has been president of the Asian Society of Fertility Preservation and president of Indian Society. And she still is very active in this field, in both in the national and international fields. And again, it's her motivation which has so that all of us have taken this field as part and parcel of IVF, and the deserving patients, they are being benefited by this initiative. And she has been recipients of lots of medals. I think the few what is written here is the just few important ones.
We can leave all that. Let's get on with the academic stuff.
The most of it, I say we are very close friends, and I'm very proud of this friendship. I personally learned a lot from her. I keep her as a role model.
Thank you. I'm humbled. I'm really humbled. So to get on with my presentation.
Thanks, ma'am. I'll just stop my share, ma'am.
All right.
Yes, ma'am.
I always get very confused with these things, but I'll give it a shot. So are you able to see?
Yes, ma'am. Yes, ma'am.
So what I thought was that we'll talk a little bit about the dilemmas we have in the management of oncofertility, and we'll sort of take it right from counseling up until embryo transfers after freezing. So a little bit of an overview or a flavor of it, because this time is too short to really go very deep into the things. But now that we don't have one lecture, I need not be so rushed.
Yes, ma'am.
You're okay with that?
Yes, ma'am. Yes, ma'am.
So I think, cancer affects reproductive health, or cancer treatment affects reproductive health. There is no doubt about that anymore. And we know that, we have cancer survivors leading very good, long lives. And if so, then we need to look after their reproductive health as well. So far as guidelines go, the oncologists have these guidelines that they are supposed to refer patients who they think are at risk of losing their fertility, and they should refer them for at least counseling or discussion on fertility preservation. But many a time this does not happen, either because there's a decisional, patients are not really listening to what the oncologist is saying because they are so scared, they are afraid of their cancer, and they don't really want to think about fertility preservation because, there could be a fear of cancer recurrence, or maybe they are going to pass this on to their offspring. So it becomes, comes very low on the priority, and also life before reproduction, which I think both for the oncologist and for the patient really become very primary. And it has taken us a lot of, discussions with the oncologist to at least start breaking this barrier that we must have a discussion, and life is definitely before reproduction. But patients must be given a chance, at least those who will have a long life, they must at least, save their reproductive ability for later on in life. So it's important that healthcare professionals don't, defer on this, and they should talk and not worry about. Many of them are uncomfortable about talking about sexuality and reproduction, especially to young females or to adolescents, and that is something that we need to overcome. So when we look at the dilemmas, so there are two dilemmas: one in counseling, where both oncologists and the reproductive medicine specialists are involved, and then dilemmas in the case managements. So far as oncologists are concerned, they have to assess the risk to fertility, and this, they have lovely charts which give you what is the treatment protocol and what is the risk to fertility. And then of course they have to look at the survival rate for the patient and the recurrence rate, and having looked at all that, they then refer the patients to the fertility preservation, to the reproductive specialists. Now, just to share with you this case, this was a young lady of 32 years old. She had been diagnosed with cancer rectum in 2014. So the plan was radiotherapy with ovarian transposition was done. Patient was advised to go for fertility preservation, but she refused. She said, I want to complete my cancer treatment. That is the priority. Now, somewhere along the line, the whole treatment changed. Instead of, just having surgery after her radiotherapy, they decided to give her chemotherapy. Now, we all know that if you give chemotherapy, it doesn't matter. The relevance of that ovarian transposition absolutely goes, because chemotherapy is going to act through the blood and it will reach the ovary wherever it is. Now, she had all of that. She had 2 cycles of chemotherapy, and then later on in 24, she got married, and now she's desperate to start a family. Her AMH is 0.01 nanograms. You can barely see 2 to 3 AFC. Somebody did try to stimulate her, but the E2 levels did not rise, and they cancelled the cycle. She came to me for a second opinion, adamant that she did not want to go for donor eggs. So what I want to bring forward over here is that oncology treatments, very often they change. They start with something, and somewhere along the line, either there is a step up of chemotherapy, or you change from surgery to chemotherapy and then radiotherapy. So therefore, it's very important that when the oncologist is counseling, one, they must ask the patient to go to a reproductive specialist. You can tell them that, it's not necessary for you to do the procedure, but at least understand the impact of what we are doing, what it is going to have on your future, and perhaps even have a independent psychological counselor rather than 2 doctors, because the moment the doctor comes into the picture, patients sort of back off, and they feel that there is some kind of a vested element here, and an independent counselor may be able to get through to them, because now this patient has very little hope that she is going to be able to conceive with her own eggs, and she is devastated. Now, what about counseling by the reproductive medicine specialist? Well, you have to understand the person's desire for fertility preservation and what are her expectations of it. Is she thinking that, okay, she preserves this egg and she's going to get pregnant? Well, we have to disabuse her of that idea. You have to discuss the benefits and the risks unabridged. Give her the complete work so that she can make an informed decision. You must tell her that alternative childbearing options are also there. They are there for the future. You can think of it that way, but everything should be laid out so that she can make a well-informed decision about it. So what are the risks and benefits we talk about? Well, in terms of benefits, she has a longer reproductive window, twice as likely to have a child if she has frozen her oocytes or embryos. And pregnancy is protective in many cancers, for instance, breast cancer or endometrial cancer, or even ovarian. It is pregnancy is protective to that. And also, of course, the psychological benefits of motherhood are there. So far as the risks are concerned, you do have to understand that there can be a loss in thawing, there is a surgical risk involved, and the pregnancy rates with the oocytes or embryos of women who have cancer are definitely lower than those who don't have any cancer. So those are some of the risks which we have to define and make them understand. So the next, of course, question, very important question which comes is it safe to undergo ovarian stimulation? Will my cancer get worse? Now, we can very, very categorically tell them there have been lots and lots of studies done, especially in breast cancer, where we know that majority of patients we get are breast cancer patients. So the studies have shown that there is no decrease in overall survival rate, or the disease-free survival is also similar both in HR positive as well as HR negative patients. And similar studies have been done in lymphoma as well, where 5-year progression-free survival remains similar for those lymphoma patients who underwent ovarian stimulation and those who did not. So safety is assured. Is it safe to get pregnant after all of this? Yes, pregnancy should not be discouraged. They do have some adverse pregnancy problems in pregnancy, and there may be some adverse outcomes, but at this point, I don't think that needs to be taken any further, and there's no point in scaring off the patient, and those can be addressed at the time the patient gets pregnant. Will my child be normal? Will there be an increased risk of cancer? Well, again, very, very reassuring. No, there is no increased risk of cancer in the child, nor are the congenital abnormalities increased. And in this particular study, which looked at health outcomes of offsprings which were born to cancer survivors through ART, no increased risk, adverse perinatal or health outcomes in the offsprings were noted. So again, a very important study and very reassuring for us as well as the patients. So then what about planning management? Once you've counseled the patient, what procedures can you offer? Now that depends on what is the time available to you. Are they estrogen sensitive tumors? Is there any risk of ovarian involvement? What is the pubertal status? Have they been exposed to chemotherapy before? And if they have any comorbidities? Always bear in mind that the definitive cancer treatment has to be started as soon as possible. The gamete preservation should be done prior to chemotherapy or 6 to 8 months after completing chemotherapy, because we know that the primordial follicle development and reaching up into the secondary recruitment stage will take that much time. So that means these follicles are exposed to the chemotherapeutic agents, will have more mutation, and the children will be at risk of problems, or even there will be, abortions and other issues like that. So wait out those 6 months till the wash-off period has happened, and then a fresh lot of oocytes has come in, which can be used for ART or other fertility treatment. Take the appropriate consent, and consent for posthumous gametes again becomes extremely important. Now, do evaluate the general health, look for all possible problems that you could encounter suddenly, and get a pre-anesthetic clearance done, because you don't want to run into a problem on the OT table. Remember, in lymphomas, they may have thoracic, big lumps, and the patient, anesthetist may have a problem while intubating the patient. Evaluation of ovarian reserve is the single most important thing that we need to do, either through AMH or AFC or both. And we know that we can calculate the dose of stimulation. We are prepared for assessing high or low response. And in patients with low response, where maybe an AMH of below 0.5 nanograms, maybe you should consider trying to counsel them against fertility preservation, or at least warning them that the outcome is going to be extremely poor, and would they prefer to go in for alternative methods of reproduction later on. So that should be there on the table. When it comes to patients who are less than 1.3, which is supposed to be the normal range. However, even between 1.3 and 1.9 nanograms, the prognosis should be guarded, because you may not be able to get those 12 to 15 eggs that you want, which really dictates success. It would, of course, depend again on the age of the patient. The younger the patient, the healthier the eggs, but the older the patient, the more numbers that you need. So give your guarded prognosis. So what happens between 0.6 to 1.2? So you're neither, in a very low status, and neither are you in the normal status. Well, again, these are the women you need to take up for fertility preservation, because she is at maximum risk of POF post chemotherapy. it is important really to know, is the patient understanding what you have told her? What is her ability to understand her realistic chances? Because whatever you offer is actually dependent on that. Don't allow her to go with the feeling that, you know, she's all set for the future and she doesn't have to worry, when actually she has only 4 or 5 eggs cryopreserved. So that is extremely important. Now, in this lady, that case I'm sharing with you, she was a 30-year-old patient with invasive breast carcinoma grade 2, triple receptor negative. The plan was surgery followed by chemotherapy and radiotherapy, and so she was referred for freezing, fertility preservation, and the AMH was turned out to be 0.48 with just an AFC of 2 in one ovary and 3 in the other. So a very poor outcome to be expected. However, given her young age, stimulation was done, and she ended up with 3 embryos preserved, at least something to fall back on. Now, what procedures you plan depend on the age of the patient, presence of a partner, the urgency to start treatment, and the general condition of the patient. And we know that prepubertal, it's only ovarian tissue cryopreservation, and post-pubertal, you can either freeze the oocytes or embryos, or again do ovarian tissue freezing if you don't have enough time. Now, oocyte vitrification gives reproductive autonomy, and let me tell you that it is very important to talk about this even to the married women. It's very difficult when they walk into your clinic and they have the mother, the mother-in-law, father-in-law, 30 other relatives, and the husband. Very difficult to tell a woman, listen, you will have reproductive autonomy if you freeze your oocytes, because at that point nobody thinks the marriage is going to break off, and the woman would be considered really looked upon with great suspicion as to why she is even discussing such a thing. So when you see these women in the ultrasound room, when they are alone with you, that is the time really to share this with them. And believe me, so far, all the patients whom I have discussed with this, who had actually come for embryo freezing, went on to have oocyte vitrification, because we know that marriages do break up because cancer treatment is not easy. It's very prolonged, and that is something which they should have in their hand. They don't want to be going to court to get back their oocytes. We need at least about 12 to 15 oocytes. Actually, 20 oocytes give at least a 70% chance of a live birth when they are frozen below the age of 35. So we know, what a delicate situation we are in with these patients.
Excuse me, Nalini, can I ask one question here?
Yeah, sure.
Because we have enough time, so I thought.
Please. It would be better actually, rather than going off.
Yeah. So, this dilemma does come in of oocyte freezing versus embryo freezing in married women.
Mm-hmm.
Especially it has happened with women coming from outside.
Mm-hmm.
When they request that you do oocyte freezing and not embryo freezing. My question is in relation to the act and consent of husband. How does reproductive autonomy for one partner stands if husband is not party to that decision?
No, she is not going for IVF. She is going for fertility preservation. There's a difference. IVF means you're fertilizing the gamete in vitro, where she needs the consent of her partner. Fertility preservation means she's only freezing her gamete, and she doesn't need the consent of her partner for that.
No, but
like a man going and freezing his sperm, he doesn't take permission from his wife.
Yeah, but in India, that everything doesn't work.
See, Umesh, I'm going to say this again, and I say it at every meeting. If we are going to ask them for every breath, should we breathe in or should we breathe out? You have a rule for that.
It's not me.
No. What I'm saying is that it very clearly states IVF, okay, is for a married couple. We are not doing IVF. We are doing fertility preservation. That means preservation of a gamete. And preservation of a gamete has to be in the hands of the woman or the man if he wants to preserve his gametes. Because, if we start asking permission for these things, first of all, it's very clearly written. Fertility preservation is very different from IVF. We are not offering IVF. We are offering fertility preservation. However, if you still feel that, but the moment you start asking, you will have 10 different regulations coming in. So I think it's very clear. It's for IVF, that is in vitro fertilization, where you're going to need the husband or the partner's permission, not if a woman freezes her gametes. So they can always fight it out in court later if the government it comes to that, though I doubt if it will, because everybody knows that they cannot sort of suppress any kind of, or they can't interfere so much in a person's reproductive life. By law, you can't do it.
I think that answers the question. I just wanted to raise this issue. That does come.
Yeah, I know it's a concern, but I think we have to also, now be very precise about what we do and how we view what we are reading, and view it in what is beneficial for the patient, rather than be always scared about, what the government is going to do. It can always be, if they have a doubt, it can be clarified.
It's not the government, it's a reaction of the husband. It's not the government.
No, that's why I'm saying never talk in front of the husband. You talk outside, and then the wife herself discuss it is with the husband, because at the time of the signature and everything, it's very clear. So let me tell you that, of course, this always happens in the educated patients, that the husband does not intervene at all. He is very okay with the woman freezing her oocytes. I've had this, at least my experience has been that. With the lower social, or I would say the middle strata of patients, I just say it, but I don't push it, because I know that the woman will land up with far more problems over there.
And Nalini, there's another question from some audience, Dr. Neelam Singhal, that cryo-freezing banks come under AIT Act. But I don't think this comes under bank. This is basically under...
No, the patient is freezing for herself. She's not giving it away.
Yeah.
So it doesn't come under a bank.
Yeah.
And really, it is my request, because I keep reading all these messages on those various groups. Please don't sort of live in entire fear. Just interpret look at the basics of what is written and interpret it simply. Don't get complicated about everything, because if you get complicated, they're sure to, put you down as best that they can. So whatever in simple language is written, very clearly written, just move with it.
And if it's not written, don't bother about that.
Yes, absolutely. Absolutely. It can always be brought up. It's not there. Yeah.
Medical judgment, and do that.
Yes, medical judgment. It's absolutely. So should we move on?
Yeah, should move on.
Okay. So of course we have embryo freezing and then ovarian tissue cryopreservation for prepubertals and for women who have to go for coadjuvant chemotherapy. And here what I would like to say is that, I have seen many papers now where they are even actually doing even if the patient needs coadjuvant or neoadjuvant chemotherapy, they are actually doing the preservation, delaying the chemotherapy by those 10-12 days, and then sending the patient off to neoadjuvant therapy. So even on the oncology front, I don't know whether it happens in India, but there are a lot of Western papers now which are, where they are doing it. So even that has now come into the realm of reality, where even the patient who has to have urgent chemotherapy, they take those 12 days quickly and freeze the oocytes, and then patient moves on for chemotherapy. So then is planning the protocol. We know that the protocol of choice for these patients will be the antagonist protocol with an agonist trigger, where gonadotrophins are started from day 2, and it takes roughly about 11 to 12 days. The dosage is based on age, BMI, and the ovarian reserve. And so far as the type of gonadotrophin is concerned, what I would like to say here is that maybe adding a little bit of LH may not be off the mark in patients, because one, they're generally older. Two, their reserves are also maybe a little lower, but more importantly, you cannot go back and change anything in a subsequent cycle. You don't have that luxury. You have that only that one cycle, and therefore we know that we've been stimulating all along with Minopure, where FSH, LH both are there. So there's no harm if a little LH is added. So you can add a little bit of LH to your recombinant so that later on, things are not growing. Then the cycle is really all done and you can't go back. So in hormone receptor positive patients, you add, of course, letrozole or tamoxifen to your ovarian stimulation regime. These are added from day 2 of the cycle, letrozole as 2.5 or 5 milligrams, and you can continue this till after the pickup so that the estradiol levels drop further. And in tamoxifen, I use 20, but you can go up to 60 milligrams from day 2, and this can be continued later on because it's a treatment for hormone receptor positive breast cancer. Now, which should you choose between the two? We had only actually a lot of studies with letrozole and not so much with tamoxifen, but now comparative studies have been done, and both are equal in terms of the number of oocytes they give. With letrozole, the concern is that the androgen to estrogen ratio in the follicular fluid is altered, and it alters oocyte morphology, which may impact the M2s as well as the fertilization. But both can be used, and they give an equal number of COCs. Now, a random start protocol is required if the patient comes in the middle of the cycle, as they very often do. We know that antagonist is added when the follicle size of the second cohort, the cohort that you are targeting, is about 12 millimeters. You do get similar M2s, but please remember that the length of stimulation goes more about minimum 2 days more. So you have to tell your oncologist that I'm not taking 11 days. It may take 13 or 14 days before I can hand the patient back for chemotherapy. Don't try to cut short because it doesn't happen. You'll just land up with immature eggs. Now, the other protocol, which is now currently, gaining a lot of ground, is the PPOS protocol, where you can give MPA or dydrogestone, either 10 milligrams or 20 of dydro. And one of the advantages is it can be given both as a flexible and a fixed protocol. So either you can start from day 2, or you can even start from day 5 or 6 and carry it on until the pickup is done. And it's equally efficacious, gives you the same number of M2s. Now, the worry over here is, what about hormone sensitive cancers? Should you give it in hormone sensitive cancers? But, that has been, we have had recently a study on PPOS protocol in women with cancer. And there it was seen that it was, good in terms of efficacy. It was good as the one with the antagonist, and of course definitely it is more economical and physically less taxing to the patient. So far it has shown a good response, and especially in patients with endometrial hyperplasia or with endometrial cancer, it is a very good regime to do, because we know that the treatment for these two conditions is progesterone. So if we are actually giving them progesterone, we are mitigating the effects of the high estrogen levels, which will automatically come when we are doing a stimulation. And this has been shown to be a feasible and a safe strategy, as also with the LNG IUD. You can leave that in situ and get on with your stimulation. It does take a little longer for stimulation, even in the PPOS protocol and also with LNG IUDs. But in terms of the number of oocytes and the maturity, it does not, affect at all. It's as good as the antagonist protocol. And when it comes to endometrial cancers, actually LNG IUD is protective in terms of a relapse rate. Now, what about the duostim protocol? Well, if you want to get more oocytes, you can do a duostim protocol, but please remember it's really physically taxing for the patient to be on stimulation for literally more than a month, and they're already actually quite stressed with their cancer treatment. So I think only the very committed patients would go there, but you can offer it to them and see how they take it if you don't have enough oocytes. What about ovarian protection with GnRH analog? We know that this needs to be started at least a week before the cancer therapy to prevent the damage to the oocytes because of its flare effect. So very often what happens is that there isn't enough time. You've just finished your stimulation and the patient is going on for chemotherapy. And if you give agonist at that point, then there will be far more follicles recruited and they will have a burnout because of the cancer therapy or the alkylating agents that are going to be given. Now, this very interesting case which I found on the net, and I think it needs to be shared. This is a 37-year-old breast cancer patient, ER/PR positive. She had an AMH of 23 and an AFC of 32. An agonist protocol was done. 22 eggs were collected. And very, very interestingly, and I really don't know what that person was thinking, one day after OPU, they gave Zoladex as a protection for the future chemotherapy related effects on the ovary. Now, of course, patient went into hyperstimulation. Now, we really don't need to do this. If you don't have time between the time you do your pickup and the time the person has to get into chemotherapy, please give an antagonist. The antagonist leads to a huge drop of E2 within 4 days and FSH LH. And after that, you can give the Zoladex or the long-acting GnRH agonist and cover for another 5 to 6 days so that the flare effect is covered by your antagonist. So in that sense, you will be protecting the patient against any possibility of hyperstimulation because of giving the agonist at the wrong time. Now, in patients where there is absolutely no risk of OHSS, patients with a low reserve, you can give the depot as a trigger. So when you give the trigger, you do your pickup, and 5 to 6 days later, when the patient is ready for her chemotherapy, she's already suppressed and the ovaries are already protected. Now let's look at some special situations such as BRCA mutation. If there is a family history of breast cancer and the patient is tested positive for BRCA gene, she must be counseled for fertility preservation because their reproductive span is reduced by 2 to 3 years. Very often they may be recommended a bilateral salpingo-oophorectomy between the ages of 35 and 40. And they do have menopause a little earlier than other patients. So it is very important to give them this option of preserving their oocytes. And it must be remembered that when breast cancer patients come with BRCA mutations, at least, though we know that when you read the literature, it's very controversial, with some people saying, yes, it is lower, and other people saying, no, it isn't. But what I have seen of all the patients I have done, we do get a lower oocyte recovery in patients who have a BRCA1 mutation. So, and it has also been shown that they have a consistent trend for reduced reproductive potential and performance of cryopreservation strategies. And this is by Lambertini, he's one of the masters in oncofertility. So definitely that is one area we should look at. Now we can do ovarian tissue cryopreservation in these patients as well. However, if it is a HR positive patient, it is, we have to remove the transplant tissue after the patient has achieved pregnancy. What about, interrupting tamoxifen therapy for a pregnancy? The positive trial, which had been going on for so long, finally last year came out with its finding that after 2 years, you can stop the tamoxifen therapy, allow the patient to have a pregnancy, and the recurrence rate is similar to those patients who did not stop their therapy. So that is extremely reassuring, because otherwise 5 and then 10 years is a very long time to wait to start a pregnancy. Now the other thing to remember, which is important, is that tamoxifen has a teratogenic effect, so you have to wait for a 3-month washout period before allowing the patient to start. And once she's completed her pregnancy, she's breastfed her child, she has to go back onto tamoxifen. Lymphomas, again, these are seen in young patients in the pediatric and adolescent age groups. The ABVD regime does not give a very high risk of POI, but there is a recurrence. There is a chance that the regime may be changed to alkylating regimes, wherein then the POI will become at 60%. The disease in itself also has a potentially negative effect on the ovarian reserve, and that has been shown in a couple of studies. So what do we do with these lymphoma patients, when they come to us as young adults or in the young age, what should be done in terms of fertility preservation. So just sharing this patient with you. She was 12 years when the diagnosis was made. ABVD regime was given. She responded very well, and unfortunately she relapsed within 8 months. And of course, then the step up of chemotherapy was done. She ultimately achieved remission, but autologous bone marrow stem cell transplant was decided. So we know that if you're going to have a stem cell transplant, then you literally everything is ablated and the ovaries are gone. She developed ITP and now was in remission since 2013. When she came to me at the age of 28, she wanted to have a baby. Her AMH was 1.24 and the AFC was, she had AFC. However, she has undergone so much chemotherapy in, over the years, and then subsequently she developed ITP. Her oncologist said that she should not have pregnancy on herself and she should go with surrogacy. But the new surrogacy laws at that time did not allow a donor egg surrogacy. And so we stimulated her, but the quality of the embryos and oocytes was extremely poor. And of course, we could not go ahead with the transfer on any surrogate. So what I'm trying to bring out here is, in these lymphoma patients, they should have a very close follow-up on their ovarian reserve. They are young, they should have a close follow-up after the ABVD regime. If everything is over, they're looking fine. But everybody forgets about the ovary because they're looking at other factors. But that should remain in play, so that if there is any signs that the reserve is going down and the child has grown up a little bit, but by that time you can offer her fertility preservation or oocyte freezing. Unfortunately, there are problems which are associated with oocyte cryopreservation in adolescent. They need higher doses, cancellation rates are higher, the response is poorer, and the number of oocytes that you get are lower. And so far, with oocytes cryopreserved in adolescents, pregnancies have not been reported, and so it's still considered experimental in this premenarcheal age group, not in those who have already achieved menarche, but in the premenarcheal groups. Talking a bit about endometrial cancer, because we're seeing a lot of... Sorry?
Again, a break.
Sure.
You said that this patient had received chemotherapy.
Mm-hmm.
So if now what about that? If patient has received chemotherapy, let's say 3 years back, 4 years back, or
this is 6 months is the time when that cohort, the follicles which are going to come through are the ones which are affected by the ongoing chemotherapy, because from primordial up until when they come into secondary recruitment, it's about 6 months. So the effect of chemotherapy on the growing cohort is gone. But we do know overall that all said and done, there is some effect even on the silent primordial follicles. But also, on the other hand, that lymphoma patients who are absolutely treated, or even leukemia for that matter, they do have spontaneous pregnancies as well. So there is the cohort of follicles which is there, or the in reserve, don't necessarily all get affected. They will manage to have oocytes which were not there in that growing cohort, and therefore they got saved from the effect of chemotherapy. So in her case, there was a long gap from 13 to 28. So so therefore there were follicles, but unfortunately, because of the cancer, because of the repeated relapse, because of the repeated and then the bone marrow transplant, the quality of the oocytes was highly compromised. As we know that when women who come after cancer therapy and they come for ART after that, their oocytes are never as healthy as the ones who don't have cancer, or if they had it before cancer. Even that is an issue.
Okay, thank you. I think we can move on. Yeah.
So talking about endometrial cancer, and the reason I want to talk about it is seeing a lot of patients coming in, young patients with endometrial cancer. Now we must remember that the relapse rate in this is very high after stimulation. It's reported as high as 50%. And the relapse occurs within the first year after treatment. So that's another reason why they're encouraged to have pregnancies fast and then get on with definitive treatment, which means removing the uterus and the ovaries. So, that really has to be kept in mind. Now, mostly we do the, preservation only after the treatment is complete. But in some patients, you may require to do it before their progesterone therapy, and those are the ones who have a low reserve to begin with, or they are opting for, radical surgery straight away. So then they, of course, need to have their, embryos or oocytes preserved before that. Now, if a person has, one child and then she says, no, I want to have a second child as well, you can, in the interim period, put in an LNG IUD so that she remains safe and protected. And of course, a follow-up is extremely essential so that, she doesn't live with this comfort that everything is fine with me. You have to keep on doing a 6-monthly ultrasound and even an MRI to see if there is, if required, to see if there is any advancement or recurrence of the cancer. Now, we know that age and the treatment time from endometrial lesions is the one that really determines the prognosis for these patients or the risk of recurrence. Now, going on to FET, a complete health evaluation, including cardiac functions, if anthracycline has been given, should.
Nandini, can we again have a, because there are few questions in chat box.
Yeah, sure.
This one, when somebody again asked about that consent, that do we have to take permission from authorities or not?
Regarding?
If you are freezing oocytes for a married woman.
No, I think please put a cap on it now. If you're so scared, don't do it. Refer the patient to us.
Don't keep on asking everything from authorities.
We are the authority. You better not go to the authorities and ruin it for yourself as well as everybody else.
And my banks are mainly for third party. They are not for self-suicide.
Yeah,
There's no confusion. It's
bank is only for, and bank now, I mean, they insisted on using this word bank. When I think I had a 15-minute discussion with them that what do you mean by a bank? They are still agents. They are just bringing you the, donor now with her screened. That's all. Earlier we used to do the screening, now they're doing the screening. They can't bank the oocytes. Then what is the difference between an IVF center and a bank? So they understood that bit, but they still kept the word. So we have to suffer it now. There is no other way.
And then letrozole, what dose of letrozole you use? 2.5 to 5?
Umesh, I hardly use letrozole. I don't like it and I don't use it because I do agree with the papers that the oocyte morphology is altered and the number of M2s are lower. And more than that, the estradiol levels go so low, you don't know whether you should be giving the trigger or not giving. I am always in that dilemma. The oocyte level, I mean, the estradiol levels are so low. So I have since long changed to tamoxifen. I don't use letrozole.
Okay. And tamoxifen, what dose?
I give 20, but people have gone up to 60 milligrams per day, but 20 milligrams per day is good enough. And then in any case, it's just 10 days and then the patient goes off, 10, 11 days.
Okay. And then there are studies in which both letrozole and tamoxifen has been used in HR positive BC patients.
Yeah, people are doing so many permutation and combination, but tell me it's a question of 10 days. So what we are dropping the estradiol level, and tamoxifen actually causes an increase. With tamoxifen, the level of estradiol will be higher. So what are we trying to achieve really? I don't understand this combination at all. That to me doesn't make, it's not logical. Because, by the time the estradiol levels go up, it's already day 6 or 7. And then in another 3 days, you're finished with it. So you're trying to protect what in those 3 days? What is the protection you're achieving? And in the time when letrozole was not given and ovarian stimulations were done for cancer patients in all these Swedish cohorts and all, they have not found any increase in the relapse rate. So I don't think it's necessary.
Ma'am, in C endometrium and CA breast also, you're not using letrozole.
Sorry? And CA breast, I'm using tamoxifen.
C endometrium, this PCOS, C endometrium.
No, CA endometrium, I use a PPOS protocol, and so I don't use letrozole. I'm not very happy with that, with it at all.
Okay, then there is another question. With LNG IUS in situ, do we need to add oral progesterone as well as for
No. It suppresses. See, when you have these doubts, it's a simple thing. Just do your LH and see where you are at. When I started using the PPOS protocol, I used to do a LH on day 6 to see has it really gone down, and am I living in some false, premise that it's down regulated, yeah, that the surge will not occur. So when those doubts are there, just do a test, you'll know where you stand. So when you have the LNG, you just do your LH and see what the levels are, and you'll know whether your premature surge
But
is.
LNG, I think escape ovulations are common. So this is what is the advantage, that yes, your ovulatory cycle does continue with LNG IUD. So I feel that PPOS in PP, if you are planning a PPOS, oral progesterone would be required.
In an LNG IUD, I have used it. I have not given oral in addition to that. But as I said, I normally, if I'm in doubt, I do an LH and see what is happening. And I think Jasneet just did one. Jasneet, please share your experience on the stimulation that you did with LNG IUD in situ.
So we had done a stimulation in a patient with endometrial CA. The LNG was in situ. She was a PCO patient, but unfortunately, the number of oocytes that we retrieved, it was actually a case of partial empty follicle syndrome. And the length of stimulation was a little 2 days more than I had expected.
Yeah, no, length of stimulation increases even with PPOS, not only with LNG, with PPOS also it increases. But so far, whatever the studies show is that it does not affect the oocyte quality. So maybe inherently there was an issue. One can't say that, but unless we have more experience ourselves with that, I've only done a couple of cases, and those were endometriosis. They were not endometrial cancer. They were severe endometriosis, and the response was quite fine. I didn't have a problem, but you only learn all the problems when you have more numbers. So I think everybody's pooled experiences should tell us where we stand ourselves. But so far the reports, they don't suggest. But definitely both in PPOS and in LNG IUD, number of days required for stimulation increases.
Okay, thank you, Nalini. I think we can move on.
Okay, then not much left now. So just about the assessment prior to FET, everything, you should have a thorough assessment. If anthracyclines have been given, then cardiac function to be checked as well. Ovulatory cycles are always preferable because of the lower risk of PIH and other things. And if patient does not have ovulatory cycles, then you may give letrozole, tamoxifen, or even gonadotropin to get the follicle going. But if that doesn't work, then of course you will have to do an HRT cycle. So don't get too worried, because HRT is given even in cancer survivors to alleviate the vasomotor symptoms of premature menopause. So if it's given there, then we should not be worrying too much about giving it for a few days prior to this. You can discontinue HRT very early. You can wean it off starting from the 8th week. And let me share a case with you, which I had also reported. There was this patient African patient who developed massive DVT at 6 weeks of pregnancy, and I had to stop everything, estrogen, progesterone, everything, and she went on to deliver at term twins. So I think the fears are more in our heart than actually what is required. So you can just start weaning off as soon as patient is nearing 8 weeks. Just gradually slow and stop it, and nothing will really happen. And of course, single embryo transfer should be the norm. So far as optimizing your outcomes, now you have few embryos and few eggs, so please optimize outcomes by doing the progesterone levels. Progesterone level before starting, progesterone should be below 0.9 or equal to 0.9 nanograms on the day of trigger. If you're planning a freeze-all cycle, you can just repeat that. We normally do it on the day of the embryo transfer, and if it is below 15 nanograms, we step up. Again, we repeat it on the day of pregnancy test, and if it is below 15 nanograms, we step up the progesterone so that the patient doesn't become negative or doesn't lose the pregnancy just because she doesn't have optimal progesterone support. So far as refractory endometrium is concerned, how do we manage that? Well, apart from the usual HRT, multiple cycles, etc., IUPRP has been tried in these patients, of course, and stem cells. Of course, the worry is that when you're putting in growth factors and you're putting in stem cells, they have the possibility of uncontrolled growth, and can you be actually reactivating the cancer? There have been some studies which have been done that, of course, they have not been done with endometrial cancer, but they have been done in other areas, which has shown PRP to be safe and no recurrence of cancer or decrease in overall survival rate. Uterus, after irradiation, we know how bad the endometrium will be. So somebody has tried pentoxifylline 800 milligrams per day and tocopherol, that's vitamin E, 1000 milligrams, 1000 IU per day for 12 months. And they did manage to get 2 pregnancies and improve the endometrial thickness. So of course, when we are in such situations, we try everything that is possible and everything that is at hand. Stem cells have also been tried. Again, the worry about safety is there. My concern about the use of stem cells in India is the way they are prepared without identification. Things are just put in. So, though I've been wanting to use stem cells, I'm very wary of asking for the preparation of stem cells, because I did speak to one unit who does stem cell, and when they told me what they do, it was I was so concerned, because they said that they'd aspirate the bone marrow, separate out the stem cells, mesenchymal stem cells. They don't actually identify except for whatever they identify under a microscope. Then they add PRP, then they expand the cells. So it was a khichdi of everything. So I think I just left it at that. But this should have, I think, a good application, but it's very invasive in nature. And so with that, I'd like to thank you all very much. And if there are any questions, I'm ready to take them on.
Ma'am, that was an absolutely amazing, very concise and very nice lecture. And in fact, I'm hoping you and Umesh ma'am will be around during our panel discussion. Or
I have some guests coming in. If they don't come in, then I'm here. Till they come in.
Yes, ma'am, please stay. We will need your expert advice for the panel questions also, ma'am.
In that case, I had something which I think still literature does not answer, and I wanted expert advice. So maybe I can ask about it here. Like more often than once, and including the case we have during the panel, the patient does tamoxifen for 5 years, then comes back, then they're looking for a pregnancy. Something goes wrong, and they then take 2 years, 3 years, 4 years, and by the time they have a recurrence. And that is when they come looking for fertility preservation. The initial cancer treated, then they were on tamoxifen, then they come back once the tamoxifen has stopped, or they never started it because they were. So there are no guidelines to say that we can do the fertility preservation before putting the patient on 5 years of tamoxifen. Everywhere they talk about before chemotherapy. Why not before putting 5 years?
Chemotherapy in those terms is endocrine therapy also. It is chemotherapy doesn't only mean alkylating agents. When we are talking of breast cancer, it includes endocrine therapy. Endocrine therapy is a part of the chemotherapy, so to say, broadly, of breast cancer.
Because everywhere the talk is about which agent will cause how much harm to the the time itself will cause so much harm.
That is very well known. Tamoxifen, we know that in itself it doesn't reduce the reserve, but the time is 10 years. By the time the woman is pretty old. So that is why in breast cancer, fertility preservation is advised across the board, whether the patient is on, endocrine therapy or is on the regular chemotherapy. And let me tell you what is happening now is they're doing all these genetic testings for testing the risk of recurrence. And these are being done right in the beginning. So even if the patient is on endocrine therapy, somewhere in between, they will change it to, if the report comes back, and it comes back sometimes in a month, 2 months, if the risk is high, they will put her onto high-level chemotherapy, alkylating agents and everything. So in breast cancer, across the board, it should be fertility preservation.
That's what, instead of, waiting till the reserve is already gone down. And also, ma'am, I wanted to know that the consent forms for fertility preservation in cancer patients, is there something specific, special available, or
So I
we
think
just kind of
they are the same.
personalize and put it to each patient? Because I could not really find any specific.
No, it's already there. The posthumous use of posthumous gametes, that tick mark is already there in your freezing reports. If there is anything additional that you want to take, you can always make something like in ovarian tissue freezing. Freezing we had made for the society some forms, but these forms contain everything, so you don't necessarily need to do anything else.
Right. And one more thing, if like somebody really has to be referred for ovarian tissue cryopreservation, OTC, where do we refer them?
Yeah, that's a big. I mean, I think Rita can help you
Yes,
there
ma'am.
because they've
Ma'am,
already
we
started
are
and
doing, Dr.
use.
Neena, yes, ma'am. We have started, Dr. Neena, and her team is doing. So, ma'am, any patient you can refer. So, the procedure is planned. So, we have established the thing. And
So,
it is free of cost, ma'am, and the patient
okay,
doesn't have to pay anything.
okay.
And recently,
I
but one case, ma'am, as they have done OTC and ovarian transposition both simultaneously also in one case. And we have Spondita,
That
our
would not be
embryologist.
cancer, Rita. That would be POI.
Ma'am,
Because
she was some
usually
cancer. Spondita is there, ma'am. She knows the case because I just, matlab, this happened during vacation. They done OTC and then I think she was for radiotherapy also. So they did the transposition also.
transposition. Oh,
Yes,
sorry.
ma'am.
I heard transplantation. Sorry.
No, no, ma'am.
Yes, yeah,
Transposition.
obviously.
Transposition. Yes, ma'am.
Transposition.
So,
Understood.
Good, good evening, everyone. Yeah, we are doing here as an ICMR project of ovarian tissue cryopreservation on mostly on adolescent and prepubertal patients who can't afford or can't undergo any type of stimulation. And well, we are doing still now. And if you have any patients who require it, you can definitely send it to us.
So they just go to the infertility department, or how it is? I mean, you have to
To our
do it really
department.
fast. It has to be on a very, very fast speed, no? So
Yes.
how do they go about it?
They have to come to the OPD and we try to give them the nearest OT date, whichever is possible
Tiny
and
OPD.
feasible. Yeah.
Tiny OPD.
I think it would be better if we are given a better just a WhatsApp message in the
yes,
group,
ma'am, we will put that. Yes,
so
ma'am.
that we have an idea, because patients, they want that some name that
Yes,
they
ma'am.
can go and contact there. So they can go
Hmm.
and ask some name, and then they will reach there.
Otherwise, they tend
Or
to
we
get.
can personally call you and tell you that we are sending
Yes.
some
Yes.
patient.
Yes. Yes.
Yes,
Yes.
ma'am.
Yes. That will be better.
Yes, ma'am.
Please put this in the group so
Yeah.
that
Yes, ma'am. We'll just drop it in the chat box. We'll put this information, ma'am.
yeah.
Okay, sorry guys, I'll have to leave. You can give me your
Asha.
questions, I'll answer them later, whenever, if there's anything specific.
Thank you, ma'am. Thank you so much,
Okay.
ma'am.
Thank you once again, ma'am,
Thank you.
for being with us. Thanks a lot.
So,
Okay.
should we proceed for our panel discussion then?
Yeah, then there don't seem to
Yes,
be
yes.
questions in the chat box.
Yeah, so although Nalini ma'am has briefly outlined on touched all the cancers, we would have a detailed discussion now as case-based discussions. And for that, I would like to invite our two distinguished moderators for this session. And first of all, I would like to invite Dr. Loveleen Kauri Sodhi ma'am. She is the Director cum Chief Consultant Gynecologist and Infertility Specialist at Dr. Sodhi's Healthcare Multi-Speciality Hospital and IVF Center at Punjab, Chandigarh. And she's the past president of Menopausal Society Region Chandigarh and running IVF Center since March 2007. And she has been honored with several awards to her credit. And she is a keen academician and who is regularly invited as a faculty to international and national conferences. And then I would like to invite Dr. Rita Mahe ma'am. She is professor in the Department of Obs and Gynae and running as a chief for one of the ART units. And her chief areas of interest is infertility, ART, PCOS, and endoscopy. And she also has several awards and several publications to her credit. So now coming to our distinguished panelist. And for this, I would like to invite Dr. Professor Shweta Mittal Gupta ma'am. She is the Secretary General of the Indian Fertility Society and Treasurer IFS from 22 to 24 and is the recipient of several awards to her credit. And also she has been credited for the first pregnancy from frozen thawed oocyte in North India. Good evening, ma'am, and welcome. Next, we have medical oncologist Dr. Akash Jha. He has done his DM medical oncology from AIIMS New Delhi and is currently working as an associate professor in medical oncology and currently posted as AIIMS Jhajjar with special interest in breast and GI malignancies. Next, please. We have Dr. Monica Gupta, who is a senior consultant Ops and Gynae at Manipal Hospital, Bhubaneswar, and she is the first super special DM reproductive medicine from AIIMS New Delhi, and she also has received several awards to her credit and has more than 20 publications in the index journals. We have Dr. Seema Singhal, ma'am. She is additional professor in the Department of Ops and Gynae at AIIMS New Delhi. And she has also received a number of awards and has number of publications in several peer-reviewed journals. And currently she is having has ongoing research on developing biomarkers for ovarian and endometrial cancers. We have Dr. Jasneet Kaur. She is the clinical director and consultant at Milan Fertility Center, Chandigarh, and she has been the reviewer of several reputed journals and has several publications to her credit. We have Dr. Sanujit Kaur, ma'am. She is the Associate Director of the Department of Ops and Gynae and Fertility at Cloud9 Hospital, Chandigarh. And she has been the past convener of the Chandigarh Ops and Gynae Society and past treasurer also of Chandigarh Region of Menopausal Society and recipient of IVF Excellence Awards at Entrepreneurs Excellence Awards 2019, Trichy, Chandigarh. And next we have Dr. Anupam Gupta. She is the senior consultant at Jindal IVF and Sant Memorial Nursing Home, Chandigarh, and co-convener of SIG Early Pregnancy of the Indian Fertility Society and ex-secretary Greater Chandigarh chapter of IFS and teaching faculty and academic curriculum. Next, we have Dr. Spondita Banerjee. She is MSc in Medical Biotechnology and currently our eminent embryologist at AIIMS New Delhi. And she's also received the certified embryologist course from ISHRE and has more than 10 years of experience in the field of ART. So welcome all of you. And we look forward to a very interesting case-based discussion and hope we have a very good interactive session. Over to you, Dr. Loveleen ma'am and Rita ma'am.
Yeah, we have Dr. Manu also as a panelist. Dr. Manu is additional professor at AIIMS Jodhpur. So she has also joined us as a co-panelist in our panel.
Okay, welcome ma'am, welcome.
Thank you. I'll just share the screen and we can start. Is my slide visible?
Not yet.
Okay. So now, can we see the slide now?
Yeah.
Yes.
You need to make it full screen.
Yeah, yes. Good evening, everyone. So as we have seen that horizon of fertility preservation is increasing and it is beyond the cancer patients also. So we have so many indications of fertility preservation. So me and Dr. Loveleen will be starting few interesting cases so that we can have good take-home messages in individual cases. So starting with the first case, this is 36 years old PCOS patient, phenotype A, so which is a severe one. She presented with primary infertility for 4 years with history of intermenstrual spotting for last 6 months. She had irregular cycles since menarche and sometimes she had to take progesterone also. And she is married for 7 years and she is obese with BMI of 35 with hirsutism score of 8 and unremarkable abdominal and pelvic findings. And in her investigations, so when she presented to us, her FSH-LS was reversed with ratio reversed and AMH was 14 nanogram per ml. And her testosterone also 0.54 nanogram per ml. So, and as she presented with irregular spotting and bleeding also, so her transvaginal scan showed uterus normal size and endometrial thickness of 17 millimeter with bilateral ovaries bulky with antral follicle count of 35 on right side and left ovary in the 40 AFC. So my first question is to Dr. Jasneet. So as we have seen this clinical presentation, she's a young obese PCOS patient presenting with intramuscular bleeding and with these findings. So how will you evaluate this patient?
Thank you, Dr. Rita, for the question. So I think before we go ahead, understanding that she is a case of severe PCO with AUB, with infertility, with morbid obesity, I think I'd first like to look at her metabolic profile also before I go ahead. So I'd like to do her fasting blood sugar levels, her blood pressure, her lipid profile, and also other hormonal profiles like a thyroid and prolactin if not done earlier. Then we know that in PCOS patients, particularly the ones with hormonal and metabolic dysfunction, adds to the risk of endometrial hyperplasia and endometrial cancer. And in this patient with AUB with an endometrial thickness of 17 millimeters, I think I'd like to do endometrial biopsy for her next. Now, whether to do it blindly or visually targeted hysteroscopic biopsy is something that needs to be discussed, because we all know that with a blind technique, we are just going to maybe curate 50% of the endometrial cavity, and it has a false negative rate of around 10%. So a visually directed hysteroscopic biopsy is something I'd like to do. The only concern with a hysteroscopic guided biopsy is that in case it turns out to be an endometrial CA, there is a risk of dissemination of the cells into the peritoneal cavity. But I think now we have enough evidence to state that if hysteroscopy is done under low pressure settings, it does not affect the prognosis or doesn't upgrade the tumor. So I think I would like to do an endometrial biopsy next for her.
Yeah, thank you, Dr. Jasneet, for the precise answer. So seeing her presentation and thick ET, so along with her basic investigation, so we should plan her hysteroscopy and endometrial biopsy. So she was planned, and so unfortunately her endometrial cancer was shown on the histopathology report, so it was grade 1, ER/PR positive and P53 positive. So this is a real dilemma because infertile patient presenting with endometrial cancer. So next question is like now how we are going to investigate further and how to counsel the couple regarding the disease. Do we have Dr. Seema Singhal joined or she has not joined? Dr. Shweta, can you please take this question?
Joined,
So,
Dr.
I will
Joined.
just
Oh,
tell you. Yeah.
we were waiting for you.
Okay,
No,
okay.
I
Is
joined.
Dr. Seema there?
Yes,
Yeah.
ma'am. I think she has come. Yes.
So, yes,
Dr.
your
Seema.
first question is about the investigations for this patient, further investigations. So our investigations will focus on basically on three things holistically for this patient. One is to identify whether this patient is suitable for fertility preservation in this particular scenario when she's diagnosed with endometrial cancer. Can we do something for that? Secondly, to assess her modifiable risk factors, because identifying those risk factors are not only important for the disease control but also for her future perspectives as well. And thirdly, will be important to assess what about her morbidities and her pregnancy, whether she is a potential candidate and she can safely carry on with her pregnancy. So the investigations will focus on these three aspects initially. So I will just focus on the oncological aspects of this, that since we all know that fertility preservation in these patients is possible only in a very specific subset of patients, tumors which are endometrioid grade 1 tumors, and the tumors which have either no myometrial invasion or a very superficial myometrial invasion. Only those patients we can do, preferably no myometrial invasion. So for that, we will go in for an imaging. Imaging will consist of usually which one to do, TVS, MRI, CT, PET CT. We have a lot of options. So TVS, MRI, remember, for assessing the regional aspect like uterine invasion, size of tumor, TVS and MRI both carry equal sensitivity and specificity. But for assessments of lymph nodes, TVS won't help. Lymph nodes, MRI sensitivity is poor, but specificity is excellent. For CT and PET CT, lymph node assessment is very nicely done, but they cannot assess the uterine factors. So it's always a good idea to go in for a CE, MRI, pelvis and abdomen to assess the overall aspect of this patient. And also we have to rule out distant metastasis. So for that, MRI is definitely there, and also X-ray chest. So these will be the oncological thing and other general investigations, plus as investigations told by Dr. Jasneet, all these things will be done. So regarding the counseling, another question is there, counsel the couple. So it's not only couple, we have to see if the family is involved, the family, the parents, most of the times they also come, that everybody is anxious. So we need to call everybody, and the team is like gynae oncologist as well as our ART team. So we do it together. Now, what all aspects are to be told? First and foremost thing, they have to be told that this is not the standard of care. Standard of care is surgical management for this particular case. But since there are a lot of technological advancements nowadays, and we have some evidence available for success of medical management for these patients, so we give her an option and tell them that yes, these are the available options for you, and if you want, you can go in for this. But before that, she has to understand that she has to this, there can be response rate of 75%, but it can be, kind of may not respond or may progress also. So that risk has to be taken. And also she has to know that she needs to be under surveillance for next time. And then once she conceives, she might require ART colleagues help for this particular work. And once she conceives, when she has a baby, she has to go in for a standard management, that is surgical management. So these aspects have to be very clear to them at this stage right away.
Yes. Yeah, thank you, Dr. Seema. So actually, all these things we need to discuss before planning her fertility preservation therapy. So this was her MRI finding. So she had thick endometrium with no evidence of myometrial invasion. So definitely, so after giving all the options, so couple opted for conservative medical management. Dr. Shweta, can we please discuss regarding the now available option to her, the patient who is keen for fertility?
Yeah, so basically, now if she's keen for fertility and she has a stage 1, grade 1, CA, we need to, number one, give her progestogens. So that's very important. Now your progestogens, normally what I give in my clinical practice is megestrol acetate. So about 160 milligrams, even up to twice daily. The second thing, so what are the three things we have used in the past? One is a high dose progestogen. The second is even adding a metformin. And earlier, we would also give a GnRH agonist just to reduce the anti-mitotic activity. The follow-up, what we do is a biopsy. We can also use an LNG IUCD, but my preferred drug is megestrol acetate. I don't know what you all use. And the second is that I would do a repeat biopsy after 3 months. I need to know that it is regressing back or not. If after 3 months I see that it has regressed, then yes, that is the time when I can offer her fertility preservation. So I think my kind of follow-up would be maybe till up to about 6 months or so. And I want that to be regressing it back. I don't want any progression. If it has regressed back, then I would offer her, if I have 2 weeks available. It's very important to be in sync with your medical oncology board. Do not hesitate to take a second opinion at any point of time. Always be in sync with your histopathologist so that you know the correct histopathology. Give them the previous reports. But I have one more experience that when you give very high dose progestogens, their endometrium knocks off. It really becomes very thin. And there were 2 cases where the endometrium just would not build because of all these procedures. Otherwise, then you can just go ahead and do fertility preservation for her, or it has reverted back, do an IVF and go for embryo transfer, make her get pregnant soon. My only concern is that an ART service will quicken or shorten her time to pregnancy. And if we let her, be the way she is, and that is the time she will get into progression. So I think we need to avail ART services the moment endometrium reverts back.
Yes, ma'am, that is important rather than leaving her for spontaneous pregnancy because she is at risk of this again cancer coming. So we should take the help of ART services in these
I
patients.
remember one girl, she used to come to us. We were treating her. Her endometrium had knocked off. So what happened was 6 months she didn't come because her husband went with a very bad accident, was in ICU. She just forgot her follow-up and then she came with, full-blown CA and had to be offered a hysterectomy because there was no way out then.
Yes, ma'am. So,
I just wanted to ask between Vegestrol acetate and LNG IUD, don't you think LNG IUD would be better? It would to have better patient compliance and to avoid the systemic effects of Vegestrol, high dose progesterones.
So
Ma'am,
I don't know, my personal experience for atypical hyperplasias is LNG IUCD, and when it was CN, C2 was Megestrol acetate, but I want to know if there's any change,
A
in
lot
the
of studies are actually showing better recovery or better response to both the combination of oral and LNG IUS, or a combination of surgical
And
resection.
including hysteroscopic
ma'am,
resection, ma'am, they're doing
I think
everything
we have
yes.
hysteroscopic resection. Yeah.
Yes, combined therapy is always preferred. And ma'am, as Dr. Shweta has said clearly, so if it is hyperplasia with atypia, then answer is LNG IUS. Then we can wait. But if it is frank malignancy, it's better that we do the combined approach. Usually what we follow, we do the Megestrol acetate. Definitely we have to give, and if she has thick endometrial lesion, then we should combine the hysteroscopy guided resection also, which will help in this better regression as early rather than just giving one progesterone.
I guess the hysteroscopic resection is possible if it is a focal kind of cancer,
Yeah,
not
exactly.
global.
That is what I
Yes,
was going to say. It is if it is the focal growth. If it is generalized hyperplasia, then only LNG IUD or systemic progesterones will work.
actually, ma'am, we have to individualize, because if it is endometrium is very thick, so like more than 12 millimeters, so then definitely hysteroscoping, or if the patient has
Yeah.
not responded, if there is persistence of disease like in our patient, so we also did hysteroscopic resection also in this patient, because the disease was persistent after 3 months, and it was again the endometrial thickness was 20 millimeter. So then that second sitting we again did the hysteroscopic resection. So again, which I think let us just discuss this case. So all the maybe things will be answered at the end of this case. So how we manage this case. So like in this patient, so again we continued on follow up. So she was started on Megestrol acetate 160 twice a day, but after 4 months when she underwent hysteroscopy, again there was residual endometrial cancer, and but this time, so again it was thick. So then this time we planned hysteroscopic resection plus LNG IUS also along with Megestrol. So definitely it's going to help. And but again the important thing is what we do in this hysteroscopic section, we have to go a little bit deeper into the endometrium, 1 or 2 millimeter deep is required rather than just removing the lesion. So definitely it's going to help the patient for reversion of disease. Dr. Shweta, would you like to please add to this?
My only question is that now by using resectoscopic resection, what was the endometrium of the patient post procedure? Because my experience is that when we give such long progestogens, the endometrium starts to become very, very thin, and later it's difficult to grow also. So this one is like a, localized focal thickening according to me. But when
Yes,
you
ma'am.
when you see diffuse, growth in the cavity, then I don't think we'll be able to do this. What was the outcome?
Ma'am, she conceived, but she had missed abortion. So we are still waiting for her frozen embryo
Because
transfer.
there have been so many patients of mine where ultimately I
Yes,
have
ma'am, we
offered them
have.
surrogacy.
Yes, ma'am. Very significant number of PCOS patients nowadays are coming with endometrial cancer on routine EA. Sometimes they are not even having any symptoms. So we are doing EA for some other indication, so it comes out to be cancer. And obese PCOS are definitely more at risk of this.
Yesterday only I got one girl. Now she's 42. She's unmarried, and she said, "You do my egg banking." So, I so much demotivated her because her ovarian reserve being PCO is pretty good. But she had a frank adenocarcinoma stage 1 with in polyp.
So then again, she will require surrogacy later on. So again, with so many
Yes.
questions. Yes, ma'am. So this patient, after 6 months, she had reversion of the disease, and now she is advised to conceive and plan for ART. So we just need to discuss now. So what type of stimulation protocol we will do in this patient for IVF?
Okay, so for for her, it's very simple. I will do an antagonist protocol. I will give her a standard dose of drug for her age and BMI and AMH. So maybe it will be lower dose because she's PCO.
Yes,
I
ma'am.
will add a letrozole if I don't want too much of estrogen working on, the endometrium. If she has an LNG, IUCD in C2, it's great. Or we can also do a progesterone, PPOS protocol. I want to actually keep her E2 levels low because we know very supraphysiological E2 levels will, make her endometrium thick. And it's going to be a standard trigger. Now, my trigger, I would like to give an agonist trigger for her because she's PCO. She would be having a little more response. And then I would do a routine, egg collection. So I think the only change what I would do is adding letrozole 5 milligram throughout the stimulation till the day of trigger.
Yes, ma'am. And ma'am, do you give letrozole after the pickup also?
Yes, so if the E2 levels, I want to keep them low, then I give it to all my hyper responders actually for 8 days so that the E2 levels fall.
Yes, ma'am. There is evidence for letrozole for prevention of OHSS in the post pickup for 7 days.
Like,
It really
today
helps.
itself, my patient was a very hyper responder. She was for PGT SR and I got many oocytes, about 30. So I've given letrozole in the luteal phase. So to all my hyper responders and to these kind of patients, I would continue it.
Yes, ma'am.
And Dr. Shweta, what is your experience with LNG IUD in situ and direct antagonist protocol? Like,
So very few patients. I have more with normal like copper T types, but I haven't seen any. I can't remember many patients because most of my these kind of patients have been on oral progestogens, but I don't see any difference. Unless what I can theoretically think, because my experience with PPOS is sometimes the LH gets very suppressed. So always should get an LH done on the day of trigger. And if the LH is less than 0.2, then my doubt is whether to give agonist trigger or not.
Then
So
it might
of a
not work.
progesterone, you should only monitor an LH level, and especially on the day of trigger to decide what trigger you want, because sometimes with agonist trigger, you can have a little catastrophe. Or if you have given agonist trigger, then after, 12 hours, do an LH and progesterone, and you will know whether your, agonist has worked or not, or do you need to give a rescue HCG.
Yes. Thank you, Dr. Shweta. So just to conclude that as our expert panelists have told that I always go for second opinion if this type of cancer comes in young nulliparous patient, and fertility preservation procedures are recommended only in grade 1A cancer, and there are few cases where it comes as grade 2 also. So but again there is limited data whether we can do fertility sparing treatment in these patients, so we need to discuss individually. Hysteroscopy is definitely preferred over blind biopsy, and preoperative assessment with MRI, as Dr. Seema said, for myometrium invasion, and combined approach should be preferred in case to case basis. And then dose of progesterone is, again, it has been discussed, and both megestrol and LNG-IUS will actually help to reduce the dose of megestrol, because megestrol acetate has its own side effects also. Sometimes patient come back with pain abdomen and this weight gain and bloating. And so the one important thing is for how long to give treatment. So do we have Dr. Seema who can any panelist can, like, for how long we can continue this treatment if there is no regression? So this is one important point to be discussed in these patients.
Yeah, so treatment usually median response time to response after progesterone therapy is 4 to 6 months. If it is a well differentiated tumor, no myometrial invasion. And if there is no response, we can change the medicine, like we can add GnRH analogs, or we can give Mirena, or we can do hysteroscopic resection, and then we can continue with the therapy. Maximum 9 to 12 months, majority 80% would regress, but beyond 15 months, it is not allowed in any of the guidelines. It is not allowed. And for the, that's what is the standard. Yeah.
Yes. Okay, thank you, Dr. Seema. So I think we have discussed this. So now I will request Dr. Loveleen, so please carry on the second case.
Thank you all panelists for a nice discussion. And so next is breast cancer. I think more and more of breast cancer in young women also we are seeing. And in some parts of the world, it has actually crossed even lung cancer as the commonest cancer among all human beings. male and female. So, since one survey even showed that 76% of these young female cancer patients without children desire to conceive, and 35% of those with children desire to have another child also. So, and breast cancer survivors who become pregnant after cancer treatment have 41% reduced mortality risk compared to those who do not, which implies that pregnancy does not negatively impact the prognosis of breast cancer. So it may possibly be protective, but even if we can't say that, definitely it does not have an adverse effect. Next slide, please. So, Jasneet, can you quickly go through what are the barriers? We keep talking about fertility preservation, but still we are not being able to do enough. For what reasons?
Yes, ma'am. So we all know that cancer survivorship is on the rise, and now the focus is on quality of life. And breast cancer patients, in fact, have a 70% reduced chance of spontaneous conception after they've undergone gonadotoxic treatment. Unfortunately, there are a lot of barriers for offering fertility preservation. Importantly, it is lack of information amongst the providers, the oncologists specifically, lack of information amongst the patients and the general public per se. Also, importantly, lack of well-defined urgent pathways or a lack of multidisciplinary collaborative effort between the oncologist and a reproductive medicine specialist. Also, once they are diagnosed with cancer, they are so overwhelmed with the diagnosis of cancer that they fear that undergoing fertility preservation is going to increase the morbidity and mortality for their cancer. And also, specifically, breast cancer being an estrogen-sensitive tumor, there is a fear that after pregnancy, there might have a worsening or relapse of the disease. And then cost, since fertility preservation services are not covered under insurance, so cost is one of a very major barrier since they're already spending a lot of money on their cancer treatment. And then availability is also an issue at times, specifically in regards to OTC, which needs to be offered in patients who are in urgent need for neoadjuvant chemotherapy. So I think these are the basic barriers. But yes, things have improved, but I feel a lot more needs to be done.
And the results of the positive trial, which came up in almost the end of last year, have shown that if fertility preservation is done in young women less than 35 years, the chances of them having a healthy baby is as much as 70%, though it may be lesser in older women. So next, please. So this is a patient. She was a 35-year-old lady. She was already married for 7 years, but just 1 year into her marriage, she had noticed a lump in the right breast, which was on FNAC diagnosed as ductal carcinoma in situ, grade 3. She underwent a lumpectomy and received radiation. And since it was an estrogen-sensitive tumor, she was put on tamoxifen for 5 years, 20 milligrams a day. She did have a family history of breast cancer in her maternal grandmother and one maternal aunt also. Next, please. So after 5 years, her mammography showed the bilateral BIRADS1, both breasts, and her tamoxifen was discontinued and she was allowed to plan a pregnancy after a 3 months break. In August, when she was not able to conceive, she underwent an ultrasound, showed a huge abdominal tumor, which I'll not go into details because this is besides the point. But then she had to undergo a myomectomy for big fibroids, with which I think she lost a good amount of time, almost 6 months of planning pregnancy. Following that, she underwent a couple of cycles of ovulation, induction, and timed intercourse. But by the time it was about 2 years since her tamoxifen was stopped, and a routine mammography showed BIRADS5 right breast, BIRADS2 left breast. The FNAC showed invasive carcinoma, ER positive, PR positive, HER2 negative, and now she's being planned for neoadjuvant therapy. And she was told to go to a fertility clinic to talk about fertility preservation. So she was nicely, adequately actually counseled about it and sent to us. Next, please. So Dr. Anupam, she comes to you with this information. What more information would you want before you can, she was told go for fertility preservation. How would you decide? What information?
Now, she's a young patient with the recurrence of breast cancer. So first, I would like to consult with her oncologist that how much time do we have before you plan this chemotherapy? How many cycles, just so that I can get optimal number of oocytes. So, and secondly, after a detailed conversation with the oncologist, I would like to see her ovarian reserve, how much is her AMH, how much is the enteral follicle count, and also I will see if she has any comorbidities. And also husband semen analysis, of course, has to be seen whether we need to do oocyte cryopreservation or we need to do embryo cryopreservation.
Comorbidities especially is important once they've undergone radiotherapy, a fetal echo, and an echo of the echocardiography of the patient is important. She may have a problem with the heart because of the radiotherapy. So yes, AMH and semen
And also
analysis.
because she has a history of BRCA mutation in the family, her BRCA mutation has also to be done. Because with BRCA mutation, there are two main things. First, because it is an autosomal dominant inheritance. So if she comes out to be mutation positive, then there's the risk of inheritance to the offspring, 50% risk of inheritance to the offspring. And so we will have to go in for PGT-M. We will have to culture all the embryos to the blastocyst and do the biopsy. And secondly, prophylactic bilateral salpingo-oophorectomy will have to be done after the childbearing is complete.
Yes.
So BRCA status, BRCA mutation also of the patient, her conversation with the oncologist, and her AMH mainly to see the ovarian reserve. All these things have to be planned.
Yeah. Next, please. So Dr. Jha is there with us, and I thought this question especially for him, that should we be checking for the BRCA mutation for all patients with breast cancer, or just when they come to us for fertility preservation? What is the protocol with you people? Is Dr. Jha there? He had joined, I think, but then
I think
okay.
Seema ma'am.
Dr. Seema is.
Yeah. Well, BRCA testing in CA breast, we have to first remember that the age is a very important risk factor. So the patients who are developing breast cancer at the age of 70, 80, we don't need to go for BRCA testing. But yes,
younger patients.
There is a patient of high grade. Dr. Akash is there, please. He's there, right?
Dr. Akash?
Yeah, he's saying somebody to unmute him.
Somebody is to unmute him.
Yeah. Hi, good
Admin.
afternoon.
Hi, Dr. Akash.
Hi. So as far as recent guidelines and scenarios concerned, right now we are going for almost all the patients for BRCA and genetic workup. As if you see the NCCN criteria and other criteria, the criteria-based workup is detecting around 15% patients, and we did a study at our place. It got published a few years back, and additional 10 or 12% patients are being positive if we select, it is an unselected population. So we have a higher number of BRCA positive patients in our breast cancer patients. So right now, the recommendation is almost all patients should go for BRCA testing.
All right, thank you. So I personally, I feel at least when you start off with the ovarian stimulation for IVF, in the meantime, even if the BRCA testing has not been done, you can do it so that we know later on if the PGT is required. Because if they come out positive, definitely PGT is very much indicated. Next, please. Quickly, Dr. Shanu, can you tell us?
Yeah, because Dr. Nalini almost covered all of this, because because across all ages, the AMH levels are 25% lower in them. They have early menopause. The ovarian, we can also plan ovarian stimulation, kind of give a little higher dose so that they form more follicles, because we need to spare some for PGT-M as well. So BRCA testing is of course important. And there'll also be implications of putting them for risk reduction BSO. So it's better that the BRCA testing is done across the board. Yes. Hello?
Hello. Yeah.
Yes.
So
This
we have already covered. Next slide, please. So oocyte cryopreservation becomes a little debatable in these patients, because when you want to put back they are the patients who are candidates for risk reducing salpingo-oophorectomy, and then when you put the ovarian tissue back, that's not a very good idea, because how long
Yeah.
that ovarian tissue stays and gives them the hormones. So the next please. Next, please. So in our patient, she had a BRCA testing negative, though a repeat one had shown some kind of variant of uncertain significance. Practically, she was negative. Next, please.
So since she's married, we can go in for embryo cryofreezing. For this, she'll have to go in for multiple cycles of ovulation induction and embryo cryopreservation. But if she desires, we can go in for oocyte cryopreservation also. Ovarian tissue preservation, I don't think is not indicated. And GnRIG also is reserved as is not the first line mode of fertility preservation. It's only if the other methods are not feasible, then we go in for this.
So for this patient, it's embryo or oocyte, depending upon what the patient's choice is. Next, please. So the interesting thing is that literature has shown 35 to 37-year-old women, when we need to cryopreserve oocytes, we need at least 20 to give them an 80% chance, or Dr. Nalini in fact mentioned 70% chance of obtaining one successful pregnancy. So herein comes the lot of counseling. And this particular paper even said that you need to do at least 3 cycles of egg freezing to give them a reasonably good chance, 80% chance. But then we know that in our particular patient, this kind of option is not available, because she's for neoadjuvant therapy and her chemotherapy has to be started at the earliest. But thankfully, her AMH was good and we could proceed directly. So, Dr. Jasneet, I think we need not go into details, agonist versus antagonist. We already know the antagonist protocol is the protocol for these patients. Dr. Anupam, would you be telling us about the random start protocol?
Yes, in random start protocols, because of its multiple wave theory, that follicles come up during any period of the cycle. So we can start stimulation at any time of the cycle. And here, along with the gonadotropins, the letrozole or tamoxifen. Letrozole in the dose of 5 milligram per day, and tamoxifen in the dose of varying from 20 to 60 milligram per day can be continued along with the gonadotropins till the day of HCG. And after ovum pickup, again, letrozole is started to decrease for about 5 to 7 days till the E2 levels drop down to 50 or 60 nanogram per day.
So, Dr. Shanu, can you tell us something about how you would like to start your antagonist, late luteal phase, early follicular phase, late
Ma'am, so
follicular phase?
if it's in the
Can you have
early
the next
follicular
slide,
phase,
Dr. Rita?
Yes, ma'am.
yeah.
Can you
So
have the
ma'am, in
next
the
slide?
early
Yes,
follicular
yes.
phase, so in the early follicular phase, you can start as usual. Like if you have a follicle which is less than 12 millimeter, you can start as usual. Start the stimulation and add the antagonist when the other follicles which you're targeting are more than 12 mm or 13 mm. But when you're starting in late follicular phase, when you have a follicle greater than 12 mm, I keep 12 mm as a cutoff. I would start with an antagonist along with the gonadotropins. I'll add antagonist along with the gonadotropins. And then if you have started, when the ovulation is just going to be there, you have a 17-18 mm follicle, then you actually wait for the ovulation or give a trigger and wait for the ovulation, and then you start as usual.
This is becomes actually like a natural PPOS cycle, because
It
she has
becomes a natural, yeah, it becomes a natural cycle, yeah. And in the luteal phase stimulation, of course, as usual, as you start in the early follicular, you start in the same way in the luteal phase, the late
so you have
luteal. Yeah.
basically, if your follicle is less than 13 mm, then you will start your antagonist as per the smaller cohort. Whereas
Yeah.
if it has already crossed 12 mm or 13 mm, then you will start with the antagonist.
In fact, yeah, to
Along with the time you start the gonadotropin and the letrozole right from the
yeah,
day one.
yeah, right from
So
the
letrozole
beginning.
in all protocols is going to be there throughout the stimulation, right from day one till the day of trigger, and then right after the egg retrieval also. Next slide, please.
Yes, sir.
So, Dr. Jasneet, would you compare with the conventional start protocol? Is there a difference? I think we have a lot of information and experience from the poor responders and rather than in the cancer patients.
So they say that the number of oocytes that we retrieve is similar, but the dose of gonadotropins required is probably 75 to 150 units more, and the days of stimulation are also probably 1 or 2 days longer with the random start protocol in comparison to the conventional start protocol.
Yeah. Next, please.
This is especially true in the luteal phase start protocol because it takes longer time for the recruitment of the follicles.
Yeah, so basically the random start, when it is luteal phase, that is the time when you say longer duration of gonadotrophin requirement. So I think we've already covered the letrozole administration. We can just move on.
And one thing with the letrozole administration, I'd like to mention, there are a few studies that have shown that if we give the agonist trigger when we are using letrozole along with the gonadotropins, the number of the oocyte quality and the number of M2s that we get is probably better as in when we give HCG trigger. So what they say is that when we are using letrozole along with the GnRH agonist trigger, along with safety issues, it also helps to improve the number of M2s that we get.
Yeah, so this
and there's also one thing, ma'am, that if you're giving letrozole, you let the oocytes grow to about 18, 19.
20, yes, 20 millimeters.
Yeah, about 19 millimeters. Yeah, so.
Yes, yes.
So either GnRH trigger or dual trigger, not HCG.
Yes, but we'll definitely not avoid HCG in a cancer patient because there is anyways a risk of OHSs and thromboembolism, high risk of thromboembolism in these cancer patients. So we definitely try to give only an agonist.
So this particular study which Jasmeet you were quoting says that actually whatever negative effect of letrozole is there, it is kind of offset and improved by giving an agonist trigger. It kind of improves the quality of the oocyte. So, and the E2 levels are actually maintained at physiological levels with 5 milligrams daily dose. They do not rise beyond about 400 in any of the patients. And the recurrence risk of breast cancers and disease-free survival remains the same. And in fact, the studies have even shown that even the progesterone levels in the luteal phase are also lower because many of these patients are estrogen and progesterone receptor positive. So even the progesterone levels remain low in the letrozole protocol. Next, please. Choice of trigger. Dr. Shweta, I think we've already discussed this though. Would you want to add anything about when to trigger? Like Dr. Shanu has already mentioned.
I can, definitely share my experience with letrozole in a luteal phase, where we do dual stim. For normal patients, we kind of stopped doing it because we were not liking a very early follicular recruitment in the luteal phase with letrozole not bringing better results. Now, this is a very special situation that she has CA breast and we want E2 levels to be very low. So then we have no other option that we will be giving. But these cycles, we can show very erratic responses. You cannot depend on estradiol level to know whether, you have reached follicular maturity or not. You will have to depend totally on your ultrasound finding. In the luteal phase, suppose you have time. I'm just talking about a situation that you've done one aspiration and you're going for second. Your ultrasonologist or you have to be very tuned in picking up newer cohort of follicles because the first few days you will not see anything other than regressing corpus luteums. So this is my clinical experience. And then after a few days of gonadotropin, you will see that the newer follicles have come up. And because you're giving letrozole, so you can't even see the rise of E2. So you're so dependent on ultrasound. Now, my trigger, whatever theoretically is being said, if they are showing a normal response, I don't think that they are going to get into thrombosis with this kind of a, right now malignancy. Clinically, we haven't seen.
And your estrogen levels are low, progesterone is also low.
I'm saying that do LH on the day of trigger and decide your trigger based on LH because sometimes your LH can be very suppressed in luteal phase. So just don't think that CA breast always an agonist trigger. Choose your trigger looking at a lot of parameters and your LH levels. If everything is fine, then yes, GnRH agonist trigger can be given. Otherwise, I would give a dual trigger. That's my take.
So not HCG alone, it has to be dual, probably along with HCG if you want to play safe, or maybe you can do the LH levels and decide. Or unless, of course,
because if clinically
it is hyperstimulating, then then
If I
it has to be.
clinically, I think number one, we don't have loads and loads of data where we can say that no agonist is performing better than HCG. I don't think nobody of us have, data
Yes.
even in hundreds.
So next, please. So I had actually kept the double stimulation question for you, Dr. Shweta, and you already answered
I can
it.
tell
Because I
you,
think you bring on
okay.
the few people with
So if I am
experience.
given 1 minute, I can tell about the dual stim. We have done it in about 500 patients now, not cancer. I'm not talking about that. My take is when I do random start, I don't look at any phase. I just start. What happens is if there's a dominant follicle, it ovulates, doesn't matter. The next cohort comes in. Even if the endogenous progesterone is rising, it doesn't matter. The next cohort comes in. Only your duration of stimulation changes. So now in a cancer patient, if the oncologist can give us 1 month, then only you can think of a dual stim. If they cannot give you a 1 month's time, then you will only land up doing one cycle of random stimulation. Only thing is after the first trigger, now in this patient, I will say after 4 days, on the 5th day, I will start gonadotropin. By the time the first corpus luteum would have died, and I start the second set of gonadotropin with letrozole again. This is what I will do. And then I will take it like an ANTAC cycle. When the follicles are about 14 millimeter, I will start the ANTAC and the trigger would be whatever you have decided, agonist, HCG, whatever.
Right.
And I will
Next.
tell her after 8 days of gonadotropin in the second cycle, in my luteal phase, I do zero monitoring, no hormones, no ultrasound, nothing is required. Just give letrozole and gonadotropin, call them after 7 days of gonadotropin, and that's the first monitoring, not even 5 days. You see nothing actually.
Right. So OTC, I think we have already talked about. IVM, does anybody have experience with IVM at all?
Not us.
Yeah. I think it's all theoretical. It's there every time, every paper, but then, and GnRH agonist during chemotherapy, again, Dr. Nalini, I think she put in a very nice point forward that like this patient, once you do egg retrieval, we must make sure that immediately if she's going on chemotherapy, no GnRH agonist is to given at that time. Otherwise, she'll get a flare and absolutely adverse effect of the GnRH agonist rather than any advantage. She'll definitely burn out even more follicles. So maybe we should convey this to the oncologist who's going to treat her that please do not give her GnRH agonist at this stage, which is something which I had never really thought of. Once we send them to the oncologist, we don't even think that, this kind of procedure can come up. Otherwise, Dr. Akash, what is your policy on giving them GnRH agonist? For all kinds of
Well, we are not,
breast cancer.
so all kinds of breast cancer, so we have to understand what are we giving it for. So after in hormone positive, young, high risk, GnRH agonist with chemotherapy has shown benefit in survival. So after text and soft trial, it is being given. But it is not the issue with related with fertility preservation. So we are not touching with that. Once we start chemotherapy, then that is the point. Fertility preservation occurs before that. If we have a plan for fertility preservation, the whole call is from, IVF people. So
Yeah.
we are not.
Ma'am, actually, GnRH agonist, I think they follow, like they send patient to us, so we do the fertility preservation oocyte or embryo. Then basically GnRH is given mainly for her maybe some protection of her own ovarian function. So it's not particularly for the fertility. So that there is
not for
some
the fertility.
yes.
So
Prevent
as
it
so
down.
I would like to interrupt here. So right now in our practice we are not giving for this prevention of POI. Right now it is only for the disease part, if at all it is being given. But in practice we are not using it for this decrease the incidence of
And what do
premature
you mean by
ovarian
for the
incidence.
disease part? What do you mean by that?
So in LH agonist has been found to be useful in combination chemotherapy a subset of breast cancer patients.
Okay.
So sometimes people do give, the data is controversial, but there are some people who gave it. Yeah. But we don't give, many times we don't give.
And in hematological malignancy, Dr. Akash?
Mm.
No, it
Ma'am,
is not
the
required in
rationale,
hematology
Because
malignancies. No.
otherwise, all the societies recommend that if you're doing nothing
ma'am,
else,
the
you can
rationale for
give
not using GnRH is that is not going to protect the primordial follicles. So what is the rationale in giving GnRH?
But only for fertility protection, not for fertility preservation. If you're not doing any, probably we just give an agonist.
Yes, it will not protect against POI because it will the alkylating agents they deplete the primordial follicles which do not have the GnRH receptors, and this will act on the GnRH receptors of the growing follicles.
So just
No, regarding the data for POI, there is a definite meta-analysis. A meta-analysis does show that it decreases the incidence of POI with GnRH agonist in breast cancer patients. So there is no confusion about that. The incidence is, I think, what I read yesterday was 15 to 30%. I mean, 30% down to 14%. So it is there is no doubt there is a good data regarding that, but it is only in breast cancer patients. Yes, not in others. Maybe it has not been studied properly, and in a lymphoma, the meta-analysis says that it does not decrease that.
whenever
So
there's a
it is
young
not about fertility; it is about only POI. These two are different things.
Okay, next, please. So she had come to us on day 4 of the menstrual cycle. Her AMH was good, 3.67 with an antral follicle count of 8 to 10 per ovary. Though follicles were of discordant sizes, her husband's semen analysis had a little teratozoospermia. Practically everything else was good. And she was already informed, well counseled. We went through the whole thing again and we got her started on the stimulation on that very day. And we sent her for genetic counseling because there was some confusion about her BRCA status. Next, please. So this is, we did letrozole along with the RFSH. And after total 8 days of stimulation, we could see around 11 follicles, more than 16 mm. And her E2 levels were just 221, and we were really delighted with this. And this is what we got, 21 COCs, but only 11 M2s. So perhaps it was because right from day 1, there were a lot of discordant follicles, and some of them grew faster, and then the smaller ones gave us immature eggs. At the end of it, we got 4 blastocysts on day 5. And then letrozole was continued. By day 6, her E2 levels had fallen to 39. And after that, she was sent to the oncology people. So this is what I was discussing with Dr. Nalini. I put a question to her that should there be a time frame for planning pregnancy after stopping hormone therapy? Like for CA endometrium, you say that, okay, they within 2 years, they should plan a pregnancy and get pregnant. Otherwise, you cannot wait indefinitely. Whereas in CA breast, why do we wait indefinitely? I've got not only this patient, many more who stop tamoxifen, then they want to plan a pregnancy and they forget entirely that they have to go back on tamoxifen also. So are there still no guidelines to tell us how long we can wait with the taking them off the anti-estrogen, the tamoxifen?
I'm sorry. Are you asking that can be interrupted tamoxifen or after
See,
completion of 5 years of tamoxifen?
Tamoxifen interrupted. She did not get pregnant in 2 years.
So there was no, So there is no data except this positive trial in which they interrupted in tamoxifen after 1.5 years, at least 18 to 30 months. They took tamoxifen, and when they desired, so at least the least was 18 months after tamoxifen, and then they gave 3 months of washout period, and they went for pregnancy. And once the pregnancy outcome was there, almost 2 years of interruption was allowed after the pregnancy, and they resumed tamoxifen after that.
Yeah,
So there was no
once,
increased recurrence.
I think when they go for follow-up for their breast carcinoma again, and if they are not, they are off tamoxifen for 2 years or so, then they should be advised to either go in for fertility preservation at that time, or they should go in for ART procedure so that they get over with the fertility part and then go back to tamoxifen, which is Unfortunately, not there in any kind of a guideline. So it set me thinking that we should have some kind of thing like that also, because more patients have come to me for fertility preservation after they have had a recurrence than after the first episode of cancer, in breast cancer. Next, please. So she has been put on tamoxifen again, and PGT-M, we are considering the BRCA status is doubtful. And what do you think, Dr. Jasneet, should we be doing after this now? Should we wait for her to go off tamoxifen again after some time? Or maybe Dr. Akash, how long would you like to give the tamoxifen? Or can she be taken off again? Or she should be asked to go in for a surrogacy only?
Ma'am, so usually tamoxifen is put in ER positive patients. Tamoxifen is put for a period of 5 to 10 years. We do have guidelines. We have guidelines from Fertility Preservation Society of India, which suggests that the patient should try for pregnancy after 5 years. But then came the positive trial, which suggested that yes, we can interrupt tamoxifen after 18 months, 1.5 to 2 years of taking tamoxifen. But what needs to be cautiously considered is that the disease-free survival and overall survival in the positive trial is only for a period of 3 years, 7 months. So that is only the follow-up data that we have till time, and that too the results came in just last year. So in case in the tamoxifen trial, she has been given a time of 2 years, I think we should actively try that she gets pregnant within this 2 years time. In case in this patient, she has been considered to be fit, other conditions have been taken care of by the oncologist, by the cardiologist, especially if she's received anthracyclines and all, then I think we need to tell her to start using these embryos and get pregnant. So the positive trial states she should get pregnant, she should deliver, and she should complete breastfeeding within this 2 years time. So I think we should consider, getting her pregnant as soon as possible if she has that 2 years gap. And rather, pregnancy is going to be beneficial. So studies have shown that it has a benefit effect, and these people rather have a better disease-free survival, overall survival, in comparison to those breast cancer patients that don't get pregnant.
Right.
Well, I have to add here just a moment for this. I think we are discussing too much about positive trial. It does not mean we have to interrupt just because patient wants
Yes.
that. The data is too early for that. It is one of the first trial. The follow-up is very less. We cannot, it just gives an hypothesis that if at all it is really necessary, it is not detrimental and it can work. But the data is too small. And it will, I mean, that small data has come in NEGM. You can understand how tough it is to do a trial like this. So it will never come this randomized or some more robust trial. The whole idea is to complete tamoxifen, get rid of the disease, get the best survival outcome out of the all chemotherapy disease, and if then things are well, then go for a preservation. I mean, this
For this patient, how long would you like to continue her tamoxifen for this particular patient?
So for any breast cancer patient, we are giving for 5 to 10 years. So 5 years are still okay. And
She had
after 5 years,
after 5 years, she stopped and she had a recurrence.
so madam,
Another
there is
5
no
years.
data. I'm not. So
We do
another
not.
recurrence is to be treated as a straight same disease. I mean,
Another 5
yeah. So if it is recurrence is late recurrence is there, it has to be treated like a new disease. So I'm sure
Right.
ki, it will again be 5 years.
Okay. So I think we can just move on to the next case.
Yeah. Okay, thank you. Our next case is a young 15 years old unmarried girl presented with bleeding per rectum, and she was diagnosed to have moderately differentiated adenocarcinoma of rectum. So she is actually planned for neoadjuvant chemo radiation. So, the Dr. Akash, so how a treatment for this malignancy is going to affect our future fertility? So can you just quickly discuss this? So,
Yeah, so in rectal carcinomas, majority of the patients, if it is localized, majority of the patients receive neoadjuvant chemo RT, and RT doses are in excess of 45 to 50 grays, and that is too high for ovarian reserves. So almost all patients, they get infertile. So that is a big problem with rectum or anything that irrigates pelvic area.
Do we have Dr. Manu here? Dr. Manu or Dr. Monica? They're there. So we just wanted to discuss like whether because she's going for fertility preservation, this chemo radiation, young 15 years old girl. So what option we have, fertility preservation option in this patient? I think they have not joined.
Hello.
Yeah.
Hello.
Yeah, Manu.
Hello. Hi, ma'am.
Hi.
Am I audible?
Yes, you're audible.
Yeah. Okay, ma'am. Actually, this girl is so she's almost pre-pubertal maybe, and she has been diagnosed with CA rectum. So we are left with only ovarian tissue cryopreservation in this patient because we can't have oocyte stimulation, oocyte cryopreservation or embryo cryopreservation in this case. So this is the mainstay of therapy or fertility preservation. And what was the next question? Sorry.
So, but again, next question, prerequisites.
Yeah,
Considering
okay.
this for OTC.
Oh, okay. Yes, ma'am. Actually, prerequisite that patient should have at least some, disease-free survival for at least 5 to 7 years before we subject these patients for fertility preservation. And proper consent is definitely required. And we don't require, as we know, that a partner or male gamete is required in that. That is not the case. And definitely we can allow for the full treatment either in the form of chemotherapy or radiotherapy, and resumption of ovarian function is almost 70 to 80% when we again reimplant the ovarian tissue. So that is the main benefit in this case. And so these are the prerequisites, and we should always have the counseling session with our medical oncology people and radiotherapy people before we go for this fertility preservation. And definitely some psychological counseling is also required for both the patient and family.
Thank you, Dr. Manu. Dr. Spondita, so can you please quickly put some light, because people wanted to see the ovarian tissue cryopreservation, so how we are following?
Yeah. Good evening, everyone. Well, we are following ovarian tissue. We are doing ovarian tissue cryopreservation by both the techniques, that is slow freezing and vitrification. As we all know that slow freezing is the freezing best method, because most of the babies born is out of this technique, where vitrification has also resulted into 4 to 5 babies. But we are following and comparing both the technique here. A portion of the tissue, what if we are getting is in the process of decortification or the whole ovary. In both the cases, we have to remove the medulla, and that can be cut in a pieces of length that is 5 to 10 millimeters in length and breadth. But the thickness of the tissue has to be 1 millimeter, 0.5 to 1 to 2 millimeters, not more than that, because the penetration of the cryoprotectants is well if the tissue is very thin and it gets this type of a thickness. After this, we in case of vitrification, we will the commercial media is available. As we all know, we can go directly into the equilibration solution followed by the vitrification solution. And in our setup or everywhere, people are using the closed system of cryopreservation and then plunging it into the liquid nitrogen. But the slow freezing technique is a little lengthy and an expensive one. Here, after getting the pieces, we are subjecting it into the lab-based media, and then a portion of the media that is known as transport media is kept with that of the tissue, and it is frozen in the same highly sterile cryovials. But the freezing of the tissue has to go in a gradual manner. That is, we start at 4 degrees. The whole procedure is done from 0 to 4 degrees. The cutting of the tissues and making it pieces, all these things are done at 0 to 4 degrees. And after that, in the programmable freezer, the temperature drops from 4 degrees at the rate of 2 degrees Celsius, 2 degrees per minute till -9 degrees, and from -9 to -40 at the rate of 0.3 degrees per minute, and from -40 to -140, followed by plunging it into -196, that is liquid nitrogen. This is an elaborate process which we are doing it, and we till now have preserved the youngest is 8-year-old girl who was about to get radiotherapy due to beta thalassemia. And our age criteria for preserving ovarian tissue cryopreservation is less than 35 years, because the lesser the age, the greater is the output.
Thank you, Dr. Smandita. So we have enough data where ovaries, the tissue has been retransplanted also back after once they are disease free. And Dr. Manu, can you please discuss quickly about the ovarian transposition also, what all things we need to discuss with our oncologist before planning the procedure?
Yes, ma'am. Actually, before we are planning ovarian transposition, actually, we just transpose the ovaries from pelvis to outside the pelvis, and we want to remove them from the field of irradiation. So we need to discuss with our radiation oncologist people that what would be their focus area, like pelvic for mainly genital cancers. We are focused for either for brachytherapy or external beam pelvic irradiation. But if total body irradiation is required, then there is a very less role of ovarian transposition. So, and the amount of or volume of radiotherapy they are going to use, because almost 14 to 16 gray will damage ovarian reserve in patients which we cater, like between 20 to 30 years of age. And so we need to discuss about the radiation dose and what would be the timing they would be giving. And because ovarian transposition has almost success rate of as high as up to 75%, not more than that. And it also depends upon the procedure, the expert laparoscopy or maybe expertise of the surgeon also, and ovarian supply, and also the use of chemotherapy if they are using. So if chemotherapy is being planned, then there is less role of transposition. Then we should go for either oocyte cryopreservation or embryo cryopreservation if the patient has a partner, or ovarian tissue cryopreservation if patient is prepubertal or at least 25 years of age. So dose of irradiation is very important.
Dr. Loveleen, should we wind up the panel because we are crossing the time?
Yes, I think we need to. We've had a lot of discussions and a nice lecture also. I think we could now.
Dr. Shweta is there with us?
Yes, I'm there.
Dr. Shweta, can you please, so because we missed the lecture of social egg freezing, so we would like you to put some light on social egg freezing. What is your experience? Then we will wind up the thing. So we wanted to hear from you.
So very quickly, I'll tell you, I'm not the person who would promote social egg freezing. I don't want to give an unnecessary added assurance to a girl thinking and saying that it's not that it's a technology not available, it's a technology. In fact, we at Gangaram Hospital have over 90% egg survival. But only thing is that we have to be very realistic. Egg freezing is not equal to ensuring a baby. I'm telling you, in last 5 years, hardly anyone has come and used those oocytes. All the emergency egg freezing, they are using it. Couples, husband couldn't give semen, TISA we didn't get, something happened, whatever. Just the social egg freezing, either they are not getting their partners, they'll get pregnant on their own. But of course, the best age is less than 35. It is not that they should think that we will not look for partners. This should not be the ideology. This should not be our promotion. But one place where I have really changed my counseling is definitely severe endometriosis. If I diagnose that in an unmarried girl, and if the girl has endometriomas, I definitely discuss. In fact, I just got two sisters. One of them was full-blown POI. She turned out to be FMR gene mutation positive. So I got the FMR done for the sister also, that in case she is a carrier, I will offer her, egg freezing. So these are the kind of, I think, cases where we have to be vigilant: early menopause, family history, sisters having POI, endometriosis. They need, egg freezing more.
Thank you, Dr. Shweta. Dr. Loveleen. So, okay, so we are just winding up. So definitely it is a need of hour, but again, not only for malignancies, it is for benign diseases also, as Dr. Shweta said, for endometriosis, but the multidisciplinary approach is very important. We should discuss individual cases, and we have to strengthen our referral pathways. And again, psychological counseling, social cost, and survival analysis. These are important factors before taking up any patient for any type of active procedure. And the very important thing is, because we all have these things, fertility, we have frozen gametes and embryos, but what is the utility option and the acceptance rate after cancer treatment? So this needs to be discussed with the patient before proceeding for these things. Thank you everyone for staying with us and to have very good discussions about these practical cases.
Thank you, Dr. Rita. Thank you, Dr. Loveleen. Thank you, SIG group. Lovely initiative and lots of, take-home messages.
Yeah,
Absolutely.
we have Dr. Nidhi Sharma. She will be giving the vote of thanks, and I would like to invite her. She is the senior consultant, Obs and Gynae and IVF specialist at Jindal IVF and Sant Memorial Nursing Home, Chandigarh, and she is the current joint secretary of the Greater Chandigarh chapter of IFS. So, Dr. Nidhi, please the vote
Thank
of
you,
thanks.
ma'am. Thank you, ma'am. Good evening, everyone. On behalf of Greater Chandigarh chapter of IFS, I am actually honored to give this vote of thanks. I want, first and foremost, actually, Dr. Nandini ma'am has already left, but I want to thank her for giving her a precious time and for excellent deliberation and giving her insights regarding the management of fertility preservation cases and how the challenges we face. We are definitely enlightened by by her talks and the points to consider while dealing with these cases. Further, I would like to thank all our esteemed chairpersons and panelists for for the expert opinions and their enlightening discussions on the day-to-day cases of management of fertility preservation. Thank you so much, all the guests and all the delegates also, for joining us and making this webinar a worthwhile point of discussion. A special thanks goes to all the organizers who have meticulously put all their efforts and in planning the event and smoothly organizing it so that it can become a smooth running event. Thank you once again, all of you. Thank you.
Thank you, Dr. Nidhi. Thank you, everyone.
Thank you, Nidhi.
Thank you once
Thank you,
again,
ma'am.
everyone, and especially commendation for Jasneet. She's put in so much effort. And thank you, Dr. Rita, for.
Thank you, ma'am. Thank you so much.
Thank you. Thank you
Thank
for
you, Dr.
Thank you,
Shweta.
ma'am.
Thank you, Dr. Shweta, for
Bye.
being with us.
Dr.
Bye.
Loveleen. See you soon.
See you soon.
Yeah.
Yes.
Okay, bye everyone.
Bye-bye, ma'am.